Uh, Good morning, everyone. The topic I am going to cover today is changes in astigmatism and higher order aberrations of total anterior and posterior corneal surface after 2.2 millimeter versus 2.8 millimeter phacoemulsification surgery. Uh, we all know that after cataract surgery, it is not only the quantity of vision, but also quality of vision, which can be deteriorated by both lower order aberration, which includes spherical errors and astigmatism, and higher order aberrations, which include spherical aberration, chromatic aberration, trefoil, tetrafoil, coma, and oblique decentration. But by adequately correcting both lower and higher order aberrations, optical side effects can be decreased and visual quality can be improved. Astigmatism and higher order aberrations can be diagnosed by investigating machines like rotating Scheimpflug camera, Pentacam or Sirius, and thus we thought we can compare pre and post operatively in different cataract incision sizes. What are ocular aberrations? They are actually deviations of wavefront exiting the eye from a chosen unaberrated reference wavefront. Lower order aberration extend from Zernike order 0 to second order, and higher order aberrations above the second order. So these are the lower order aberration: piston, tilt, astigmatism, and spherical errors, whereas the higher order aberrations start from above second order, that is trefoil, coma, tetrafoil, secondary astigmatism, and secondary spherical aberration. You see, these higher order aberration, even after you have achieved good quantity of vision 6 by 6, but the quality can be deteriorated by these higher order aberrations, and so we need to do something about them. Trefoil and coma are significant higher order aberrations. And these aberrations, unfortunately, cannot be easily corrected with non-invasive procedures or devices such as spectacles and contact lenses. So best is to prevent development of these higher order aberrations. And these aberrations can be measured by aberrometers, which can be outgoing and ingoing. And so our aim was to assess changes in these higher order aberration of total anterior and posterior corneal surface after 2.2 millimeter versus 2.8 millimeter cataract incision surgery. So we undertook this study in 300 patients of around 18 months from November 2020 onwards, and it was a prospective interventional randomized comparative single-blinded study which was done in Department of Ophthalmology, Deen Dayal Upadhyay Hospital, New Delhi. So these were the exclusion criteria: patients having any ocular disease, patients with previous history of ocular trauma, ocular surface disorders, or patients who were uncooperative for Scheimpflug segment imaging testing. And all these patients underwent complete ophthalmological examination, and they were operated by a single surgeon and followed up over a period of 3 months. And we divided these patients into two groups. Group 1 underwent 2.2 millimeter incision, and Group 2 underwent 2.8 millimeter incision. And not only the pre-operative measurements were taken, but also post-operative measurements of these higher order aberration were taken at first week, third week, 6 weeks, and 3 months post-operatively. And these were the statistical methods which were used. The independent sample t-test and other statistical tests were done, and so we arrived at these results and observation. So this is the depiction in the chart form of anterior corneal astigmatism at 2.2 millimeter versus 2.8 millimeter at 3 millimeter and 5 millimeter zone. Similarly, posterior corneal astigmatism was compared, spherical aberration of anterior corneal surface was compared, coma of anterior corneal surface was compared, and then trefoil of anterior corneal surface and spherical. Then we came to the posterior corneal surface, and all these aberrations were compared again. Spherical aberration between 2.2 and 2.8 millimeter, coma in posterior corneal surface between 2.2 and 2.8 millimeter, trefoil, and was also compared between these two incisions. So what were our results? We found that although both anterior and posterior corneal astigmatism increased after phaco surgery, but they came back to pre-op level by 6 weeks. And difference between 2.2 and 2.8 millimeter were not significant in anterior surface, but they were significant in the posterior corneal surface as far as astigmatism was concerned. And spherical aberration, there was hardly any change between the two groups. But what was significant was that there was increase in magnitude of coma at both anterior and posterior surface immediately after surgery. Similar thing was found in cases of trefoil. And we found that this was much more in 2.8 millimeter as compared to the 2.2 millimeter at both 3 and 5 millimeter zone. And these were the studies which have been done earlier, and they've also found, since there is no way to correct, better ways to decrease the incision size from 2.8 to 2.2 millimeter so as to increase the quality of vision after phacoemulsification surgery. So what we found was, although there was increase in posterior corneal astigmatism, but it was not statistically significant. But what was significantly important was that increase in higher order abrasion was much more in trefoil and coma, in much more in 2.8 millimeter compared to 2.2 millimeter group. So these just changing from 2.8 to 2.2 millimeter incision can yield better visual outcomes, especially in the early post-operative period. So what I feel is we should not only promise patient quantity of vision, we should also promise patient quality of vision, because so many of these patients having gained 6/6 vision are not totally satisfied, because the quality of vision which they found is not very good, and they keep on complaining. So to decrease the number of these dissatisfied patients after cataract surgery, I think we should also lay significant stress on improving and decreasing higher order aberrations after the cataract surgery. Thank you, everyone.